So now we're going to talk about chest tubes. So the reason for a chest tube is it says use of gravity or suction. So what I've seen in practice is a lot of people put them to suction like after surgery. And then once the patient is doing better, they'll say, okay, just let gravity do its thing, see if you can get any more out. And then we'll take it out. So, but it is to restore the negative pressure in the pleural cavity by removing the fluid or the air that's in there. So it allows the fluid or the air to escape but not re-enter. So water seal and gravity are the same thing. I don't know if she mentioned that in class or not. I think in the lab we talked about it. But if you put them to suction or water seal, it's that negative kind of pressure to like suck out. If you just open it to air, then or like gravity, it just flushes out on its own. It's not necessarily suctioning, but water seal and gravity are the same thing. It's not being suctioned out by the suction canister. So your atrium, but like your canister that it fills up in, this. So it's A through E, I think, and it just shows different things that are on there that show you like that it's working. So it's a one-way valve, dry seal system. It suctions, you can regulate that between 10 to 40. And then the orange bellow that like pops up shows that suction is operating. And then on the very bottom C chamber, if you see bubbles, that there's an air leak. So nursing interventions, you have to secure the tubing to the patient. So they're going to have like a dressing on it. Assess the dressing. Usually people don't like to change them too often, but you need to assess it, make sure that it's not leaking, make sure that it's securely on there. Keeping the unit below the insertion site. So I've seen where nurses will like attach it to the bed, which is great, but the second that you put that arm rail back up, it's not lower than the insertion site. So sometimes I see people like take them to the floor, but just keep them, like if my chest tube is up here, keep the canister lower than it. That way it drains properly. Check the insertion site at least every 12 hours. So once a shift usually. For a crepitus, make sure there's no air leaking around there. There's no excessive drainage, signs of infection, intactness of the tube, and then document the output. So you'll see Sharpie marks and it'll say like, at this time, my initials, this is how much was out into the canister, or out into the drainage collection system. Never clamp the tube. That can cause a tension pneumothorax. If you clamp it, like they're getting out to go to the bathroom or they're getting out of bed to go to the bathroom or whatever, do not clamp the tube. Whenever it's clamped, air cannot escape, and then it causes a tension pneumothorax. She has it underlined and bolded. I'd know it. Air leaking in the chamber. So that I think is C. Is that correct? Yeah. C down here is where you see if air is leaking. And then it has 1 through 5 line marks. So if air is leaking, it is present in the pleural space. If air is present, bubbling will occur. So determine the source. So how to determine the source is taking like clamps. I know it says never to clamp the chest tube because it can cause a tension pneumo. But if you like clamp to see if the bubbling stops and then unclamp it, it should be fine. Momentary clamping it from closing the drain system. So if here's my draining system and here's the tube that connects to the patient, you're going to start closest to the draining system. And if you clamp it and bubbling is still occurring, the leak is somewhere in that collection system. It's not tubing or to the patient. Then you're going to take like 2 clamps and go up. And then if it's still happening, it's below somewhere there, go up. So if you don't see any bubbling when you first clamp, you're going to go up. Still nothing, up, still nothing, up. Oh, now it, like if you get to the point where you don't see bubbling anymore, like it's bubbling, it's bubbling, it's bubbling, it's bubbling. Oh, it stopped bubbling. The stop of the bubbling is between these two. It's below this one somewhere. So you might have to get new tubing. You might have to get a new drainage system. You might have to reconnect new tubing to the patient. Just depends on where the leak is happening. Sometimes if it's a very minor leak, they'll try and like tape up where the tubing is, where the leak is, because it's a good chest tube placement and they don't want to have to like take it out because there's a leak. It just depends. You'll see where the bubbling is. It goes from 0, 1, +1, +2. And then it goes 1, 2, 3, 4, 5 across. But it just depends on how big the bubbles are, how often they're occurring, if it's constant bubbling. It just depends. So if bubbling stops, see, this is where I got confused, and then we had to ask people in lab, and it was very confusing. If bubbling stops, air leak may be from the catheter. So it's from the connection or the patient's chest. That's what confused me, though. You're supposed to start here at the drainage system. So you clamp it, it's still bubbling, clamp, still bubbling, clamp, still bubbling, clamp. Oh, stopped bubbling, which means the leakage is somewhere here. If I clamped up right above it, it's right below. So if the bubbling continues, then there's a leak in the drainage system. Water can fluctuate. So like when you breathe, when you'll see that level of water, and when you breathe in, it might rise, and breathe out, it might decrease. Like it'll, like your respirations in the water will go together. It might like increase or decrease depending on if you're breathing, like exhaling, inhaling. But water movement isn't an issue because it just proves like you're breathing in, you're breathing out. Like the water is just moving with it. The drainage or the dressing change. So if you see drainage or if it's time for a they don't really like to do dressing changes unless it's ordered, like you need to change this every certain amount of hours. So hand hygiene, gloves, remove the old dressing, assess the site. Just like anything like central line dressing change, you do the same thing. Or if you're changing like an IV, hand hygiene, gloves, take the old one off, assess. So open, so you're going to want a petroleum gauze to put over that site. I know in her class, she likes to tell you like, use like petroleum jelly for this and not for this, or leave it open on 3 sides or 4 sides. Robin's your best person to ask for that. I know she's kind of specific about it. But you're going to take a 4x4 gauze and then a 4x4 dressing change or drain dressing. Again, hand hygiene. Now you're going to use sterile gloves because it's a entry into someone's body. So it's going to be a sterile procedure. Place the petroleum gauze, and then the 2 4x4 dressings over the insertion site. Place another 4x4 gauze on top of that drainage gauze because you don't want to just leave like petroleum gauze out and then it's going to get everywhere. So you're going to put another like clean, dry 4x4 on top of that. And then you're going to tape it. Tape dressing covering completely. And then mark it with date, time, initials. So usually it says dressing changes here appear. And if it's extremely, if it's a lot of drainage and you need to change it, change it. If it's looking good, you don't need to mess with it, don't mess with it. Notify your doctor or your attending or healthcare provider if there's increasing crepitus. So sometimes it's a little normal around that site to have a little air because you stuck a tube in there and you're expecting air not to follow, but it's going to follow. But if there's like increasing amounts or more than you noticed or it's getting worse, let your person know. If you have a new air leak in your system, tell them. If drainage is more than 150 mLs every 2 hours. So if you do hourly rounding and you're checking it, and then you're like, last hour it was like 100. Ooh, now it's 100 again. It's 200. So it's over 150 for the past 2 hours. Tell them how much it's taking out because that's a lot of drainage to happen in 2 hours. If there's a change, if it was like fresh red blood and now it's like really brown and clotty, or if it's brown and clotty to fresh red, that's an issue. You know that they're freshly bleeding again. If there's clots, if you have a decrease or a sudden decrease in drainage with respiratory change, your patient's not doing well. You're not draining everything out, and then their respirations are changing because it's not taking whatever needs to be out. Respiratory distress, or if anything changes. So I'm going to talk about pulmonary embolism in my next video.